Next up are the payers. And so we'll be discussing payer initiatives to support pediatric behavioral health care delivery from leaders of the Commonwealth, two largest commercial payers, as well as the largest public payer, MassHealth. Emily Bailey is the Chief of Behavioral Health at MassHealth, where she serves on the MassHealth executive team and oversees behavioral health policy and programs across MassHealth. Jill Borrelli is responsible for behavioral health program at Point 32 Health and in leading the execution of the organizational vision to provide best-in-class behavioral health benefit delivery. And Dr. Sandhya Rao is the Chief Medical Officer and Senior Vice President for Blue Cross Blue Shield of Massachusetts, where she is responsible for strategic direction and ongoing operation at Blue Cross Blue Shield of Massachusetts Health and Medical Management and Pharmacy Division. I'd also like to introduce Amy Rosenthal, the Executive Director of Healthcare for All, who will be moderating this panel.
Hi, everyone. I'm Amy. Thank you to the Hospital Association and Children's for pulling this together, although I would like to say, like, putting the panel on, like, insurance after Kevin. I don't know if Kevin's still here. Kevin and, oh, where are you? There he is. Kevin and I now know each other through the Harvard School of Public Health, so it's great to be here with all of you. So hello, everyone. I'm going to just jump right in so that we can stay on time. So let's start just broadly first. We'll go down the row. If everyone can just talk about some of the behavioral health initiatives that are front and center for you at your company or agency right now, that would be great.
Sure. Well, am I on?
Yep.
Okay, thanks. So we heard earlier from Secretary Sutters, and I have the privilege to be part of the MassHealth team that's executing on some of the behavioral health and equity roadmap, 1115 waiver initiatives, as well as the behavioral health roadmap initiatives. And the behavioral health roadmap initiatives, of course, are in some ways being executed through the MassHealth benefit for, of course, we serve, as Secretary Sutters says, many youth in the Commonwealth, but those initiatives are done in close collaboration with other state agencies, including the Department of Mental Health and the Department of Public Health. And we are very focused on initiatives to increase community access, to provide alternatives to emergency departments through upcoming initiatives, and some current initiatives that we've been executing over the last 2 years. Recently providing $1.5 million in grants for increase in pediatric behavioral health urgent care for communities hardest hit by the pandemic. We're very proud of that, to increase behavioral health urgent care access for youth and families in the Commonwealth. Increasing specialty services for youth with autism spectrum disorders and intellectual disabilities, including the development this year, I don't have a go-live date, but of a CBAT for youth with autism spectrum disorders, specialty units, as we heard about today, as MassHealth have had the privilege and opportunity to support some of the development of those units, additional beds, among other rate and other investments that we've just been really proud and focusing on access, time to treatment, and community alternatives to acute care.
Hi, everyone. I'm Jill Borrelli. I'm the Vice President of Behavioral Health at Point 32 Health, and Point 32 Health is the parent organization for what was Legacy Tufts Health Plan and Legacy Harvard Pilgrim. And so I was talking at lunch with folks about just this. One of the things I personally think is the best part of the combination of our two heritage brands is that we've had an opportunity to really dig in and rethink how we approach behavioral health as an organization. I should say that Emily was my predecessor in this role, and she definitely got the ball rolling. And so a lot of the good work started long before I was in this role. But one of the things that I think is really has been front and center for us as an organization is to really think about behavioral health, much like Secretary Sutter said, is an essential part of healthcare, and a focus of our integration of behavioral health has been that behavioral health needs to be woven into every single part of our organization. So whether it's the call center, whether it's the sales team, whether it's the many clinicians who work throughout the building, we all need to be thinking about behavioral health. And so some of the strategies that we're working on obviously is integrated care, again, one of those terms that are used regularly and frequently. And our integrated care teams, which serve our Medicaid members, our Medicare members, and our commercial members, are integrated with nurses, behavioral health care managers, community health workers, and pharmacists. So that's a really key component of our work. We are also so focused on the access crisis and recognize that you could have as many new providers, and I think many people have spoken about this today. We could open our network up to everyone, and we have, to all qualified providers, and there will still be an access issue. So we're taking this in a lot of different small steps. They're not all super exciting programs, but it's a number of small things that we think will help, whether it's standing up a team that is dedicated to support BH providers, because BH providers are essentially, most of them, single shingle small business owners, and so fully recognizing that they don't have the administrative infrastructure or time to spend dealing with the working with a health plan. So we are standing up a team of people who are fully dedicated to supporting that cohort of providers. We are also constantly evaluating where, utilization management is part of the structure and part of the function of a health plan, but we're consistently evaluating where does it add value, where does it add hassle, and quickly trying to eliminate wherever possible where we're showing that it doesn't have any impact on quality of care. And then last but not least, this is another thing we were talking about at lunch, is that, I always tell people I speak insurance and find the health system hard to advocate, and the behavioral health system is even harder. And one of the things we're doing is standing up a team of service navigators who will be it's a non-clinical team that will be fully dedicated to all of it. In fact, goes live on Monday, starting with our Medicaid business, fully dedicated to helping members access care through their health insurance benefit and for behavioral health care. So we're really excited about all of that. And I kind of lost the punchline. One of the parts of Point 32 Health coming together and part of our BH strategy is that all the behavioral health is insourced. So currently today, Legacy Harvard Pilgrim has their behavioral health care for our commercial membership outsourced to Optum Behavioral Health. And part of the decision of coming together as an organization was to insource it. And it goes back to what I was saying before, is the reason, a large part of why we wanted to insource it is we wanted it to be integrated into everything we do. So let me stop there.
I'll be quick, Amy. So a lot of similar themes. First, hi, everybody. Thank you. It's been a really wonderful day. I've been taking a lot of notes and have been moved to tears more than once. So I'm just grateful for all the conversation. So many of you know, we've at Blue Cross had a deep commitment to mental health for a long time, having insourced it many years ago. And so going into the pandemic, we were starting to see the need to expand the network, in particular for children. And so we created this program called CPIP, where we provided an incentive to draw some providers into the network with increased reimbursement rates, also asked for some participation in quality programs, et cetera. And that yielded about a 45% increase in the network, about 60 new providers, which seemed great. Of course, going into the pandemic, once the pandemic started, we saw that that was just grossly insufficient. It was never going to be enough. And so we said we really needed to rethink what we're doing. So we have refreshed our strategy and just briefly, the two themes that we are focused on are really thinking about augmenting our network with new and different models. So I've been listening, I've got the message on CHWs, got the message on school programs. We're trying to think about team-based models that can provide psychiatrists with leverage so that more patients can be seen. So it's programs like Brightline, how we can promote even further the integration of primary care and mental health. And then there, as you all know, there's a real proliferation of new tech-forward models in various specialty areas, so we're bringing some of those in. So really trying to rethink about the network. But another thing we learned through the pandemic was that the network is only, if you said, the network's only as good as people's ability to navigate to it. It's getting so confusing. It already was confusing. Now with all these new models, it is extremely confusing. So like Jill, we're shifting resources away from towards more high-touch navigation. And so similarly, we've launched a hybrid digital and human navigation program where families can access through our app or through a human and really walk through the process, what level of care might be appropriate for you. Maybe self-service, maybe a psychiatrist, and we're trying really hard as possible to pull people through and actually get an appointment and follow them, make sure that appointment happen. And the last two pieces, we're focused intensely on equity. We've migrated our mostly primary care payment model to include incentives for closing some of the health inequities. There's a lot of work to be done to bring that to the mental health area. And the last is caregiving. We're hearing a lot of concern, passion, interest from our customers, that is the employers around the state, in caregiving. It is the health of people who are caring for loved ones, and we know there are intense mental health issues with that population, and so we're thinking about what kinds of programs we can do for them.
I love hearing about navigation as an organization that runs our helpline. I know the importance and value of that. I also want to pick up on my next question on something that you were just talking about, which is the inequities, and picking up after Kevin's presentation and really thinking about what is the role that each of your entities can be playing in working with providers to address racial disparities in the behavioral health space. Anyone want to go first?
Sure. Part of the privilege to work both on the 1115 waiver and the behavioral health roadmap is that health equity is a foundational tenet in both of those things. So in everything we do, in every initiative that we're putting forward, in every conversation that we're having with our managed care partners or internally on how we're advancing policy and program, we're thinking about through that lens, how can we make sure that we are providing better, different, and more responsive access to people, especially given what we know about behavioral health disparities for persons of color and linguistic, non-English speakers. How do we navigate that world, appreciating how vital it is to make sure people have the services they need, especially young people, especially in the wake of the pandemic and the mental health crisis that we're facing, but also given what we know about the current workforce challenges and what the current workforce looks like and what languages they speak. So how do we think about that and navigate that? And we just have a lot of highly dedicated people being as creative as possible, but in the policies that we've been able to put forward at MassHealth, really asking for our providers or our managed care entities or other partners to tell us how they're thinking about it as well. So really putting it at the front of the conversation and making sure it's not the rote responses that we're sort of all used to giving in this realm. So I'm really really privileged to be part of an organization that's really thinking deeply about this while it's still incredibly challenging and will continue to be.
So at Point 32 Health, we, as I had said before, serve the continuum. We have Medicaid members, we have Medicare Advantage members, and we have commercial members. And as you know, in the BH space right now, there's 1,000 apps and digital providers. Every day there's one new shiny penny with the next best thing since sliced bread. And we are looking very hard to identify who will be the right partners with us. But our go-in approach, and this is very different for either legacy organization, is our first question to them is, that's great, you want to see our you want to serve our commercial membership, but what's your pathway? How do you serve our Medicaid membership? How do we think about this for our Medicare membership and everything in between? What's been surprising to me is that that is a question that surprises so many of the vendors and folks that have approached us, that we are thinking holistically and inclusively and making sure that there's not a two-tier mental health system for all of the members that we serve. So that's just one example.
Yeah, so I think many of you are familiar with our payment model, the alternative quality contract. It has incentives for hitting quality measures. We are embarking on a multi-year path to include incentives for achieving equity by racial group for those measures, some of which are related to mental health. We've also been funding some infrastructure in the practices, and probably the most powerful thing is that we're giving each of our systems data on their current performance, if you will, in each quality measure stratified by racial group. What I believe needs to happen to bring that work to mental health is the development of valid quality measures for us to engage our practitioners on and have that kind of conversation, to be able to look at those data by racial group, and then, use tools, whether it's incentives, data, or infrastructure to support practitioners in closing those gaps.
Jackie, are you wanting me to keep us on schedule or do 30 minutes? 8 minutes, okay. I'm no workforce for this other one. Let's do short answers on innovative role that you play as a payer in working to retain and attract staff. You've talked about workforce. You've talked a little bit about incentives for increasing the workforce, but are there other things that either you're doing or you think you should be doing? Keep going in the same order.
It's an obvious statement, but the way that we pay for things changes how things are delivered. And in behavioral health, it's not particularly sophisticated how we have historically paid for things. And it's in large part been a challenge for providers to innovate or be flexible or use staff to do alternative roles or sort of clinician extender roles because of the way the payment infrastructure works. It's a CPT code with this type of person. This is how many minutes you have to see the person, and this is what you get paid. It's sort of set us up in the system that does not allow for creativity and incentivization naturally. So as a payer, and I've been doing behavioral health payment for most of my career. I'm a social worker by training, but have been doing this for a long time. Payers really have a unique position in the behavioral health system infrastructure to help the system and the providers that we have in our networks think about innovation by allowing flexibility in reimbursement to allow space for them to do that. In many ways, the way that the medical services community can do, because they have financial flexibility in other ways. So that is sort of foundationally how we've been thinking about reimbursement for behavioral health, because we need to allow the people, the practitioners, the clinics, the services, the soon-to-be community behavioral health centers, the flexibility to be able to meet patients' needs without having to be so rigidly tied to what, in my opinion, are sort of becoming outdated payment structures, so they can be creative, use different clinician types or folks that support clinicians to do that work. And how we pay for it really is going to change how those services are delivered.
Okay, so moving down the line, a couple of different things. One is, part of our, as I was talking about our integrated care teams, we also on staff have peer specialists who work with folks with substance use disorder and are part of the care team. And we are actively thinking about how we expand that in terms of supporting folks with mental health or behavioral health issues, as well as part of the integrated peer specialist teams. And much like what Emily said, I do think we need to think creatively as a field in terms of how we incorporate people with real lived experience to other ways to serve people. Not everyone needs therapy, right? That's not the right path for everyone. And we need to be very creative and work in partnership with providers to identify the right spot along the acuity spectrum and really challenge ourselves to think differently, whether that's through value-based payment models or other structures. There's a lot to be done in this space. We just recently created a value-based payment program with an organization that is essentially a medical home for autism spectrum disorder. So we have an arrangement with the organization is called Cortica, that children who receive care through them, through this particular provider, they have a developmental pediatrician. They also have OT speech therapy, family therapy, individual therapy, and ABA services housed within the same setting. This is pretty innovative and different. There's not a lot of these kind of autism medical home. And rather than pay for making them ask us for one session after another, we say, here, for this particular clinical picture for a child, here's your bundle payment, and then have regular ways. And I think we have to challenge ourselves as an industry, both payer and provider, to really be thinking of new and different ways to engage on these kind of arrangements.
Agree. Do you want to move to a different question?
Sorry. All right, I would say the last question I have is, and asking you to be looking at oneself and your company or agency, what are you not doing now that you think you should be doing or would like to challenge your organization to do in this space in the years to come?
I go first.
I'll start. Yeah. I come from the delivery side where I was on the other side of Blue Cross for many years, really pushing for new delivery models. So I do really believe in the power of the payer, the health payer dollar to bring new types of care to people in new formats, if you will. So I really am listening to what you all are saying about school-based settings and community health workers and the power of all of us figuring out payment models to bring those to standard of care, and this tension we hear about sustainability. Sustainability is such a theme today. So I'm going to take that back to the team.
So I think given the situation for behavioral health, there's a million things to be done. And so I think, okay, I don't mean to keep referencing our lunchtime conversation, but one of the things we were talking about at lunch, again, was how confusing it is that CBHI is called one thing for Medicaid members and something different for commercial members, and how confusing that is for providers and members, and quite frankly, the plan as well. And so how do we make those small, simple things that will really make, and take the time, because that, while it might seem like a quick fix, like just call it all the same thing, is actually very complicated. There's a lot behind it. So how do we address the small things while we're also thinking about the big things in terms of helping people access and navigate the care
I
world?
appreciate your reference to that CBHI after the conversation earlier, so thank you.
I'll be very brief. I think one of the things that we collectively can do better, I'll switch up the question a tiny bit, is reflecting on Jill's comments. We need to build a behavioral health system that is accessible to everybody, not a Medicaid system and a non-Medicaid system. So I really look forward, as we're executing in early 2023 and throughout 2023, on the really innovative and exciting initiatives in the behavioral health roadmap, and the really exciting initiatives being supported by the 1115 waiver, and working across payers, across carriers in the Commonwealth to really make sure we're all on the same train, even if we're not in the same car. But we definitely need to all be on the same train, and I think that we can challenge our collective selves to do more collaboration in that front.
You gotta just let me do my advocacy thing for 1 second, which is the things that I loved that I heard here were attention to people's linguistic needs, navigation support, payment models that support CHWs, peer specialists, people with lived experience, school-based models. I appreciate all the listening that you all have done, so thank you.